Welcome to the second virtual preceptorship in male infertility, the landscape of male infertility factors in assisted reproductive technology. I'm Sandro Esteves, and I will be chairing this live session directly from Campinas, Brazil. This program has been coordinated by MEDEA, which is Medical Education Academy. I will just provide you some information about MEDEA, and then also the introduction objectives of the preceptorship. So I need my slides. Okay. So MEDEA is Medical Education Academy is a global medical education provider that is dedicated for developing, implementing, evaluating medical education programs. We offer support to healthcare professionals in professional development, also providing education that can, at the end of the day, improve patient care. MEDEA has independent and international pool of scientific experts based on clinicians, people in academia, also psychologists, nurses, and leading healthcare professionals with a very strong background in education and also scientific publications. There are several therapeutic areas in MEDEA, including reproductive medicine. Particularly concerning reproductive medicines, we have a board of experts led by our scientific director, Dr. Robert Fischer from Hamburg, Germany. I am proud to be one of the experts in this particular area. You see many faces and names that I believe you know well from across the globe, and these people are actually helping us to deliver fine contents for education to all of you. Specifically concerning this male infertility preceptorship, I want to provide you some information. Besides myself, this program has been coordinated by co-chair Dr. Matt Coward. Matt is reproductive urologist. He was previously associate professor of University of North Carolina at Chapel Hill. Now he's head of the male infertility unit at Atlantic Reproductive Medicine Specialist in Raleigh, North Carolina in the United States. Our co-chairs are Professor Carlo Alvigi from Naples, Italy, Dr. Robert Fischer from Hamburg, Germany, and Professor Peter Humayden from Aarhus University and Skive Fertility Center in Denmark. And Peter will also be hosting one live session on December the 10th. Our program has partnered with many societies, including the Algerian Society of Reproductive Medicine, the Brazilian Society of Assisted Reproduction, the Brazilian Society of Human Reproduction, and also the Brazilian Society of Urology, São Paulo chapter, the Spanish Fertility Society, the Italian Society of Fertility and Sterility, the Poseidon Group, the Portuguese Society of Reproductive Medicine, the Turkish Society of Reproductive Medicine, and also the Tunisian Society of Gynecology and Obstetrics. I would like to give a big thank to all of these societies for endorsing and sponsoring our program. Our program is not only live sessions. MEDEA has created a platform, a web platform fully dedicated to this program that includes video lectures, surgical procedures videos, laboratory procedures videos, and all the live sessions that we have today. If you go to the e-learning platform that MEDEA has created, and you see the link below, medeaacademy.com, event May 2022. In addition to the contents that we are providing this year, we also incorporated the contents that we had last year during our first male infertility virtual preceptorship that was held between May and June. And in that particular program, we also included several video lectures and surgical video procedures. So please, if you haven't done that yet, please have a look in the contents that we prepare for you, that it will be available for you to watch. For this program, I'm very glad that we have over 600 delegates from 65 countries. We have a split between people in which having more than 10 years experience and less than 10 years experience in the field. And you see that the participants, they are quite busy in the routine daily practices, seeing a lot of patients per day. So I welcome all of you to our program this year. The second virtual preceptorship in male infertility has been accredited by the European Accreditation Council for Continuing Medical Education, and also it has been submitted for accreditation to the CPD certificate services in the UK. So today, we are directly speaking to you from Campinas, Brazil, from Androfert Clinic, and with me, I have several of our team members helping me develop this program. We have Fabiola Bento. Fabiola is Androfert General and Quality Manager. We have Ricardo Miaoka, who is also reproductive urologist. Arnold Ackerman, reproductive urologist. We have Marina Viana. She's urologist, fellow in male infertility and reproductive medicine. We have also from our laboratory, IVF laboratory, Sidney Verza Jr., senior embryologist, Maria Gabriela Mulato, laboratory andrologist, and Tainá Moraes, also embryologist. They help us prepare the program that you see today. And we also have the invited professor today, Professor Jorge Halak. Jorge is medical director of Androscience. He's a professor of urology of the University of São Paulo. And George has been working intensively during the COVID-19 pandemic, conducting studies that have been critical to help our understanding in the effects of the SARS-CoV in the male reproductive and sexual health. So I'm very happy that George accepted my invitation to join the program this year, because he will present some very interesting information about the studies that he has conducted with his group concerning this particular topic. So here you see the faculty disclosures. Specifically, we have from Dr. Ackerman that he will discuss published literature and personal experience with off-label hormonal treatment in male infertility. Mine are related to the receipt of grants and contracts from Merck, and honoraria or consultation fees from Gedeon Richter, Merck, Medea, Event Planet, and Sanita Nova. And from Dr. Miaoka, he declared receipt of grants and contracts from Astellas company. Briefly, this is the agenda we have today. This is my part. I will just complete in a minute. Then we have the visit of the clinic by Fabiola. She will present a video for you. Then you'll see a summary of one of the video lectures that is available in the e-learning platform on sperm DNA fragmentation in male infertility. After that, you'll be able to respond to some polling questions on sperm DNA fragmentation, followed by a case study that we will present by Dr. Miaoka, and then we have a discussion with our faculty and participants on this particular topic of sperm DNA fragmentation. After that, Professor Halak will summarize his talk on COVID infection and implications for male reproductive health. After George's lecture, again, some polling questions related to his talk, followed by a case study. after the case study, we'll have a discussion on COVID-19 and the implications for male reproductive health. And after that, we will have clinical case discussions prepared by our group. And with that, I will conclude the meeting. So this is a 3-hour program, and I hope you enjoy. Well, you can post your comments in the chat room anytime during the meeting. I mean, these are not for you to post questions. This is just for kind of communicate with other participants, greet other participants, say whatever you want. So this is available to you. But if you have any questions, please use the Q&A button that you see on your screen to submit your questions during the sessions or, I mean, after that. So please, you can post your questions anytime, and we will address your questions at the end of each session. Also, there will be polling questions at the end of each session and also during the case studies. You can enter your answer. Your answer will be anonymized, and the results will be collated, and then we will display the results to get some understanding from the participants on their views and experiences on the specific topics. So also very important, you need to complete the post-webinar survey you will receive by email. And this is very important for you to get the CME certificate, the certificate of attendance, and also a diploma signed by the chairs of this program. Again, I was talking about the educational materials. This is, if you haven't seen them yet, please go to the e-learning platform that you can watch the educational materials for your preparation for the next live sessions. Actually, I want to share with you the next live session that will be in about 1 week on Friday, December the 2nd. This will be hosted by Dr. Matt Coward directly from the United States with his group. I invite you to participate as well. And then on December the 10th, directly from Denmark, we will have a session hosted by Professor Peter Humayden and his group in the Skid Fertility Center. So thank you very much. And at this point, I would like to handle the session to Fabiola Bento. Fabiola is co-founder of Androfert, and she was responsible for implementing and the certification of our quality management system according to ISO 9001. Fabiola serves as Androfert's administrative and quality manager. She has written a bestseller textbook on quality management for ART clinics that is translated to other languages, and contributed many other articles and book chapters in the field. So I would like to invite Fabiola to take the stage and give us a tour of Androfert Clinic.
Thank you, Dr. Sandro. I'll take this opportunity to welcome all participants and wish you all a great preceptorship. As images are better than words, we're going to start with a short video showing Androfert infrastructure and also talking about some of the services that we offer at our clinic. So I now invite you all to watch our virtual visit. Thank you. Welcome to Androfert, Andrology and Human Reproduction Clinic. My name is Fabiola Bento. I'm the quality manager, and it's my pleasure to be your guide during this virtual visit. Androfert is a private clinic founded in 1996. It's located in the city of Campinas in São Paulo State, Brazil. Campinas is the core of a metropolis of 2.6 million people and is the third largest city in the state. It is served by a major international airport and major roads, and is only 90 kilometers from the state's capital, São Paulo. Androfert is a standalone fertility center fully equipped to offer all kinds of fertility treatments. It's also the first ART center in South America to obtain a full ISO 9001 certification. Our facilities include a referral andrology lab and sperm bank, an operating theater for egg collection, hysteroscopies, and male infertility surgeries, 2 IVF labs, as well as cryo rooms. All these areas are certified clean rooms with a centralized air quality control system. A full range of outpatient surgeries are performed in our operating theater, including microsurgical procedures such as varicose repair, vasovasostomy, vasoepididymostomy, epididymal and testicular sperm retrieval. Hysteroscopies, egg collections, and embryo transfers are also performed in our operating theater. Androfert has 2 clean room IVF labs that can operate independently. Our labs carry out all kinds of assisted reproductive procedures, including IVF and ICSI, blastocyst culture, pre-implantation genetic biopsy, time-lapse imaging, as well as embryo and egg vitrification and sperm and testicular tissue cryopreservation. Our andrology lab offers basic and advanced semen analysis, including assessment of sperm DNA damage and sperm cryopreservation. Androfert has many consultants associated with its ART program. The clinic's staff members total around 31 people. Besides providing fertility treatments, Androfert is also engaged in education. It has trained many national and international doctors and embryologists over the last years. Our clinic has been recognized by the Brazilian National Agency of Sanitary Surveillance as a model fertility center for the last 10 years, and it provides training for the agency's inspectors. Following our commitment with education, Androfert has partnered with Unicamp, State University of Campinas, one of the top 5 universities in South America. Our partnership is with the Department of Surgery Division of Urology. Senior residents of its urology program rotate in Androfert as part of their subspecialty training. We also have research collaborations with international centers in the United States, Denmark, and Spain. Together, we have achieved an outstanding scientific production and have become a referral center for male infertility. Thank you very much for watching. We invite you all to come and visit us personally when you have the chance to come to Campinas. You are all invited. I'll now present Dr. Sandro Esteves, who will be giving the first lecture. Dr. Sandro is the medical director of Androfert. He's a professor of urology at the Faculty of Medical Sciences of University of Campinas, Unicamp, and an honorary professor of reproductive medicine at Aarhus University, Denmark. Dr. Sandro is a board-certified urologist specialized in male reproductive health and a consultant in reproductive medicine with over 25 years of clinical experience. He has built a solid clinical research portfolio, designing and executing studies examining the relationship between male infertility and assisted reproductive technology outcomes and treatment protocols for infertile couples undergoing ART. His interests also include quality management systems for fertility clinics, reproductive endocrinology, and developing models for patient consultation and treatment planning. Dr. Esteves is the co-founder of the Poseidon Group and holds leadership positions in the WHO Infertility Guideline Development Group and the Brazilian Society of Urology in the São Paulo section. He is a member of the MEDEA, Medical Education Academy Technical Committee for Reproductive Medicine. He also serves as an associate editor of Andrology, Frontiers of Endocrinology, International Brazilian Journal of Urology, and SIU Journal, and is an editorial board member of a dozen of journals, including Nature Reviews Urology. Dr. Esteves is the author of 10 textbooks on infertility and reproductive medicine and has published over 350 peer-reviewed scientific papers. His H-index is 66 and his citation count is over 13,000. He's a frequently invited speaker at major national and international meetings. So now I give the floor to Dr. Esteves and his presentation of the first lecture. Thank you.
Thank you very much, Fabiola, for the kind introduction. Now it's my pleasure to share a concise version of a talk that is available in the e-learning platform. In the e-learning platform, you can get access to the full version of this talk that has been recorded. But for the purpose of the discussion today, I will try to kind of summarize its main aspects. I think it's important to start by the definition of male infertility because we are talking in this preceptorship about this issue. So male infertility is characterized by the failure to establish a pregnancy caused primarily by factors affecting the male reproductive system. And then we have many factors, including congenital, genetic, anatomic, endocrine, functional, immunological, genital infections, chronic illness, cancer and related treatments, and also sexual conditions incompatible with intercourse. It's important that these factors can coexist and also being magnified by lifestyle factors that could, affect negatively the male fertility, including obesity, smoking, environmental and pollution exposure, advanced paternal age, and also use of licit and illicit drugs. So then it's important also to understand that this is very big problem. Male infertility, we don't have precise estimates, but we can actually have some data indicating that about 18 million men globally are affected by male infertility. The contribution of male infertility varies widely between 20 and 70% of all infertility cases. And this is also an important issue because it also indicates that we need more data, certainty data from different studies to get more precise estimation about male infertility. But one key issue is that several of the conditions I mentioned before, they are associated with oxidative stress. And oxidative stress is key element that could break the DNA strand breaks in sperm. So oxidative stress is a critical factor, and the DNA is where everything starts. So it's very important that we pay attention on this issue of sperm DNA fragmentation, in my opinion, because we have increasing data indicating that sperm DNA fragmentation levels are higher in men with infertility compared with fertile counterparts. Also, elevated sperm DNA fragmentation levels are associated with reduced fecundability measured by longer time to pregnancy, recurrent pregnancy loss in natural pregnancies. And although it's a bit controversial based on the studies you see, we have data indicating that it also has a negative impact on medically assisted reproductive outcomes, in particular IUI and conventional IVF. And there's also been a recent discussion about the potential transfer of the genetic defect using assisted reproductive technology that could potentially affect the offspring health. So I think we need to pay attention on sperm DNA fragmentation. And if we go for assisted reproductive technology, which is main focus also of this preceptorship, this is, to my knowledge, the largest systematic review and meta-analysis looking to the effect of sperm DNA fragmentation on IVF and ICSI pregnancy outcomes. And this compilation of 70 studies, including, over 15,000 cycles, indicated that sperm DNA fragmentation negatively impacts IVF and ICSI pregnancy outcomes, regardless of the method that has been used to assess sperm DNA fragmentation. And the other important thing is that when we go for, when we exclude female factors, the odds ratio becomes even higher, indicating that, the male factor contributing to infertility in IVF and ICSI is quite significant. Other important aspects relate to miscarriage risk in IVF and ICSI pregnancies. It's possible to have a pregnancy in patients, in a couple in which the male partner has elevated sperm DNA fragmentation, but the risk of miscarriage coming from that particular pregnancy is increased by twofold when actually we look into miscarriage rates in pregnancies established by couples in which the male partner has elevated sperm DNA fragmentation. So let's now translate this odds ratio, for example, an odds ratio of 2.7 shown in ICSI studies, indicate that if your IVF center performs around 1,000 IVF ICSI cycles per year, and the pregnancy rate that you achieve in your program is about 40%, neglecting sperm DNA fragmentation will have an effect of minus 80 pregnancies than expected. That could lead to an absolute live birth reduction of about 15%. The question is, can you afford such a loss? We can't. And this is why in our program, we incorporated sperm DNA fragmentation testing during the male infertility workup. The testing can be done by 4 main assays: the sperm chromatin structure assay, SCSA, the sperm chromatin dispersion test, or the halo test, this is SCD, the tunnel test that can be done using fluorescence microscopy or flow cytometry, and the COMET assay. These are the 4 main tests that are used to assess sperm DNA fragmentation. There are other tests like amylin blue, toluidine blue, chromomycin A3, but these tests are more related to sperm chromatin compaction, not actually sperm DNA fragmentation. So these are the 4 tests. In our program, we use the sperm chromatin dispersion test routinely as part of the male infertility workup. And here you have a glimpse of what are the results of the population that we see. We have about 53% of our patients seeking fertility advice or fertility treatment with elevated sperm DNA fragmentation, considering a threshold of 20% for the SCD. And if you go for a threshold of 30%, which several programs use as the threshold, we have approximately 30% of our population have elevated sperm DNA fragmentation. And it's also important that 17% of our patients with conventional semen parameters completely within the normal range, they have elevated sperm DNA fragmentation of higher than 30%. So having a normal, let's say, or within range, basic semen analysis does not mean that the patient has normal sperm chromatin integrity. And that could be a reason, for example, for having a patient a couple with unexplained infertility. This is a paper we published this year in Fertility Sterility, in which we wanted to see how reliable is the sperm chromatin dispersion test to evaluate sperm DNA fragmentation. What we did in this study was we wanted to check the intra-individual agreement of the results obtained from the same man. I mean, I need to make a clinical decision, and I need to, based on a sperm test, which is the SCD in this case, I want to know if I repeat the test, if we will be in the same category or you change the category, because it will be very critical for actually decision making. So in this study, we looked into 2 semen analyses within a 3-month interval of 219 men. This is a collaboration study with the group of Professor Gonzalez from Spain. And we found a substantial agreement between pairs of results. And 80% of patients were classified into the same sperm DNA fragmentation class when we stratify as normal, below 20%, intermediate, between 21 and 29%, or high, higher than 30%. The HALO test is interesting because it can implement it in the andrology laboratory. We have protocols now, internal quality control. We run the test with negative and positive results. And you can see, for example, the HALO means that the sperm has no sperm DNA fragmentation, the chromatin is intact. And when you see no halos around the sperm, this indicates that the sperm has sperm DNA fragmentation. This is something that can be implemented in the lab. And also in this study, we found that intra-class correlation coefficient was very high, indicating no substantial variability in the results obtained. So we have been using the test for decision-making in our program routinely. And we incorporated actually the results of sperm DNA fragmentation in the report of the semen analysis. So this is how it looks like in our program. We have, let's say, the full basic semen analysis according to the WHO criteria. We'll just go back one. Here we see. Yeah, and here you see that we incorporate the sperm DNA fragmentation results in the semen analysis. So the patient result, the reference values, the number of cells analyzed, and also the positive and negative control. So this is part of the semen analysis, and we feel that by providing the clinician with a full overview, not only of the basic semen analysis, but also functional test looking to the sperm chromatin, is valid to help us understanding the paternal contribution of the sperm chromatin into the infertility and also guide possible clinical decision making. So into 2020, we published a guideline. We summarize the evidence and provide clinical practice recommendations for sperm DNA fragmentation testing. This paper was done in collaboration with several reproductive urologists, including Matt Calvert, that is my co-chair in this program, also Professor Zini from Canada, Donald Evanson, Jaime Gonzalez, and Sheena Lewis. They are, and Rakesh Sharma from the United States, Sheena Lewis from the UK, Jaime from Spain, and Don Evanson from the United States. They have been actively developing the tests that we use nowadays, with the help also of Professor Peter Humaydan, who will be hosting the last live in this program, who is a reproductive endocrinologist. So this is a paper that is free for you to download and look into the results. It has several information on the testing, indications, interpretation, and what we can do to kind of alleviate sperm DNA fragmentation. But if I can provide, let's say, a snapshot of what we are talking about, the 4 tests that I mentioned before. The test needs to be done using the neat semen, using 2 to 5 days of abstinence, validated protocols and thresholds. And in terms of the thresholds, the idea is that if you have a threshold over 15 to 25, depending on the test, there's an increased risk of male infertility. And using thresholds of higher than 20 to 35%, there's a decreased pregnancy probability by IUI, IVF, and ICSI. So this is information I want to highlight. And we have 7 main indications for sperm DNA fragmentation testing, including patients with varicocele, unexplained and idiopathic male infertility, recurrent pregnancy loss from natural pregnancies, before IUI, IVF, and ICSI, fertility concern in patients with risk factors that could contribute to oxidative stress and sperm DNA fragmentation, and also before the sperm freezing. We believe that, and we provide evidence in this paper, that in these conditions, it's very important to have a comprehensive male infertility evaluation that could potentially identify risk factors and conditions that could be treated. We could also provide lifestyle advice, and then we could enhance the success rates of the treatment we provide to our patient, including IVF. So I invite you to have a look in this paper that will provide more information about that. And the sperm DNA fragmentation testing has been recognized recently by several guidelines as an important thing to consider, including the ASHRAE recurrent pregnancy loss guidelines, also the European Association of Urology guidelines on sexual and reproductive health. This particular guideline provides a strong recommendation for sperm DNA fragmentation testing in the assessment of couples with recurrent pregnancy loss from natural conception or failed ART for men with unexplained infertility. Also, the AUA, American Urological Association, ASRM, American Society for Reproductive Medicine guidelines for diagnosis and treatment of infertility in men provides an expert opinion recommendation for couples with recurrent pregnancy loss to be evaluated by karyotype and sperm DNA fragmentation testing. And more recently, we have now the 2021 WHO Semen Analysis Manual that put sperm DNA fragmentation testing as part of the extended examination. In previous manuals, sperm DNA fragmentation testing was considered research protocol only for research purpose. And this new version completely changed the scope of the test, putting it in evidence for extended examination. So now we need to consider that, okay, we have the workup with the sperm DNA fragmentation testing. We understand that the sperm chromatin damage could contribute to infertility, and sperm DNA fragmentation has been associated with varicocele, idiopathic male infertility, inadequate lifestyle factors, unexplained couple infertility, chronic disease, genital tract infection, and then these are the areas that we could provide, interventions to alleviate sperm DNA fragmentation. In this paper, we wrote with the Italian group of Manuela Simoni and Daniele Santi. We provide an overview of all the interventions that could be used to alleviate sperm DNA fragmentation testing. This is an open access article published in Andrology in 2020 that includes how actually we can avoid factors promoting oxidative stress. This is lifestyle modification, oral antioxidant therapy, treatment of underlying conditions, for example, infections, varicocele, alleviate, also controlling better the diabetes, metabolic syndrome, and so on. Also, some evidence concerning hormonal therapy using FSH for patients with elevated sperm DNA fragmentation, and assisted reproductive technology, in particular, the use of ICSI, and in particular case of failed ICSI cycles, the possibility of using testicular sperm for ICSI. This is just an example of a trial that we did with the group of Denmark, in which we look into lifestyle interventions, simple lifestyle interventions actually. The patients were advised to follow the Danish Health Authority guidelines on quality of life. We also provide a simple daily antioxidant combination for these patients for 3 months. And what we found in this study was a reduction in sperm DNA fragmentation in only 3 months of 7 percentage point, absolute reduction of 7 percentage point, relative reduction of about 30%. I mean, we can combine simple interventions, and this is just a pilot study, but indicates that there are things we can do. We also have evidence from 6 prospective observational trials on use of FSH therapy, specifically recombinant FSH in this study, showing that the treatment could decrease sperm DNA fragmentation. The mean difference in this compilation done by Daniele Santi and his group from Italy was actually around 4%. I mean, all these interventions can be combined, of course. So the treatment with follicle stimulating hormone, as I showed you, usually is using 75 to 150 international units twice or 3 times a week for 3 months. And the principle relates on the fact that FSH stimulates DNA synthesis in spermatogonia and spermatocytes and acts on Sertoli cell to enhance survival of premeiotic germ cells. So the administration of the drug may reduce sperm DNA fragmentation through these germ cell pro-survival properties that counteract the intratesticular intrinsic apoptotic pathway. So this is one of the treatments that we can provide. Also, we can treat the male genital tract infections. There are data indicating, and we know that the inflammation, the infection increase a lot the inflammatory response that will exacerbate the production of reactive oxygen species. And the leukocytes are like huge producers of ROS that could impact the sperm chromatin integrity. We have data that using antibiotics to treat the infections, specifically using quinolones, macrolides, and tetracyclines, we can decrease sperm DNA fragmentation. In one study, it was showing that 91% of affected subjects had a decrease in sperm DNA fragmentation rates, and 80% couples conceived. And the lower sperm DNA fragmentation levels in this particular study from Spain, the main difference was between pregnancy versus non-pregnant couples were actually the sperm DNA fragmentation reduction. So this is also something to consider. This is another study we published last year, Infertility Sterility, that I did in collaboration with my colleagues, Mateus Roque, reproductive urologist, and Felipe Lira Neto, also reproductive urologist from Brazil. We compiled the evidence of varicocelectomy on sperm DNA fragmentation. And in this study, we found that using 19 studies and over 1,000 patients, that the weight mean difference was minus 7.2% in reduction of sperm DNA fragmentation, which was around 30% relative reduction from baseline. In this study, also very interesting, we did meta-regression analysis, and we showed that the higher the baseline sperm DNA fragmentation rates, the higher the treatment effect. So this is something also to consider. We do in our program microsurgical subinguinal varicocelectomy, as you can see in the slide. On the right side, we can identify the lymphatic vessels, we can identify the veins and the artery, and we use the intraoperative Doppler ultrasound to be able to even be more accurate in the identification of the arteries that sometimes comes not only 1, but 2 arteries we see sometimes, and even 3 arteries in some cases. So it's important to preserve the blood supply to actually improve the fertility after varicocelectomy. And actually, we have data indicating that postoperative sperm DNA fragmentation rates was significantly lower in men from couples who achieved pregnancy that has been submitted to varicocelectomy. So again, important thing to consider. And the last part I want to touch upon is about ICSI using testicular sperm in preference of ejaculated sperm. And the hypothesis here is that testicular sperm might overcome the oxidative induced sperm DNA fragmentation that we observe in the ejaculated sperm after transit through the epididymis. So the treatment would be to use testicular sperm because it has been shown that testicular sperm have lower sperm DNA fragmentation levels compared to ejaculated sperm. And then ICSI using testicular sperm could actually allow a lower risk of having sperm DNA fragmentation in that particular specimen using for the sperm injections. So here is kind of diagram provided by the group of Monica Muratori from Italy, in which the difference between the oxidative stress that occurs during the epididymis transit and post-ejaculation, in which at the end of the day you have more sperm oxidized and exhibiting sperm DNA fragmentation, we can possibly overcome that by taking sperm from the testicle in selected cases. So this is a compilation of the literature. This is a paper we published in F1000 Faculty Reviews, looking to the evidence on testicular sperm in non-azoospermic males with elevated sperm DNA fragmentation levels. We have observational studies primarily. We don't have any randomized controlled trials so far, but the evidence indicates that we can achieve significantly higher pregnancy rates by using testicular sperm in this condition. Also, one of the studies actually in that analysis came from our group, published in Fertility Sterility in 2015. This is a prospective cohort study that we included over 170 couples. These patients, they had idiopathic oligozoospermia and sperm DNA fragmentation levels above 30% using the sperm chromatin dispersion test. And we did in this study ejaculated sperm in one group and in another group testicular sperm. We found that the miscarriage rates was reduced, live birth was increased by using testicular sperm for ICSI. And in this study, the number needed to treat by testicular sperm ICSI versus ejaculated sperm ICSI to achieve one additional delivery was around 5. And very interesting in this study, we look into the sperm chromatin dispersion test results, particularly using, in this case, the fluorescence microscopy. This is the halo test applied to the fluorescence microscope. And we found a 79.7 relative reduction in sperm DNA fragmentation rates when we compare ejaculated sperm with testicular sperm. So there's significant reduction in that case. It seems safe to utilize surgically retrieved sperm from non-azoospermic men with high sperm DNA fragmentation for ICSI. We have data from the Cornell group showing that sperm aneuploidy rates using FISH and NGS molecular karyotype were not increased by using testicular sperm versus ejaculated sperm. It was quite the contrary. And we also have data from our group that we presented in 2019. It was evaluation of over 300 couples undergoing ICSI with testicular sperm. We had men with non-obstructive azoospermia, then we had men with high sperm DNA fragmentation, and we compared to ejaculated sperm. So here you can see in the graph that the probability of having euploid blastocysts were not decreased by using testicular sperm in men with high sperm DNA fragmentation. It was comparable with the ejaculated sperm. So we are not actually, it seems that the data indicates we are not increasing the risk of aneuploidy by using testicular sperm in this particular condition. So what we do in our program, this is our algorithm published in European Urology Focus some time ago, that we apply the sperm DNA fragmentation testing. If it's high, it's very important that we start, if not done yet, a comprehensive andrological evaluation to identify and correct possible factors that could be alleviated by treatment. And then if the treatment is done and the sperm DNA fragmentation is still high, then we go for testicular sperm for ICSI. So this is something that we are using in our program, but obviously we need to provide the andrological comprehensive evaluation. I'm just coming to the end of my talk. I will conclude with some key points, and I invite you to start, if you're not doing that yet, posting your questions in the Q&A box. Please feel free to do so. And then we need to conclude that sperm DNA damage has adverse effects on male fertility, couples' reproductive success, both in vivo and in vitro, and might impact offspring health. The testing is not a replacement of the semen analysis, but it will add independent information about sperm quality. And I believe that integration into fertility clinics may improve diagnosis, counseling, and treatment planning. The andrological evaluation is critical because it will be useful to identify potentially correctable conditions, also modifiable lifestyle risk factors, and also health-threatening illness or associated comorbidities requiring medical attention. Remember, these patients are young. This is perhaps the first opportunity the doctor will have to address overall health of patients seeking fertility. Male infertility is a marker of overall health. We have data indication that is associated with comorbidities and an increased risk even for mortality. So we have the power to interfere in a way that we could provide these patients counseling and also treatment to improve fertility and the overall health. Concerning treatment, we understand, based on the evidence we have available, that a reduction in the sperm DNA fragmentation rates could improve the probability of achieving natural conception, downgrade the assisted reproduction method, and increase the chances of successful reproductive outcome using IUI, IVF, and ICSI. What we have in our hands, we have the varicocele repair, we have antibiotics for, male accessory gland infection, exogenous FSH for idiopathic infertility, interventions for a healthier lifestyle, combination of lifestyle with oral antioxidants, use of methods to select sperm populations in the laboratory, including testicular sperm for ICSI. So the end is prevention, management of male infertility. These are integral components of comprehensive sexual and reproductive health services. And the ultimate goals for us as healthcare professionals working in this field are to improve the overall health, pregnancy prospects, life expectancy, and offspring well-being. So thank you very much for your attention. Now I will immediately handle the session to my colleague, Dr. Miyaoka, that will actually post some questions for you to answer. We have some polling questions now, and after that, we will have a case presentation by Dr. Miyaoka. Thank you very much.
Well, good morning, everyone. I don't know if, am I on? Okay. So good morning, everyone. My name is Ricardo Miyaoka. I am a reproductive andrologist, partner with at Androfert in Campinas. I would like to thank you, Sandro, for this kind invitation to participate in this program. And first of all, congratulate you on the excellent presentation that you just gave us. Thank you very much. So we have some polling questions about the presentation that we just saw. So if we could see the polling questions on the screen. So the first question is, which tests can be used to measure DNA fragmentation in sperm? So A, tunnel, chromomycin A3, aniline blue. B, tunnel, SCSA, SCD, and COMET. C, chromomycin A3, immunobeads, and Papa Nicolau staining. And D, peroxidase test, aniline blue, or entologene blue. So please, everyone, go ahead and vote. We'll give you 15 seconds to vote, and we'll see if the audience has a consensus on this. And I'd like to reinforce that if you guys have any further questions on this presentation, on the others that are about to come, go ahead and feel encouraged to use the Q&A box, and I will try to address them by the end of the sessions. So we have the results here. So A, tunnel, chromomycin, aniline blue, 4%. Tunnel SCSAs, SCD, and COMET, 91%. Chromomycin, immunobeads, and Papa Nicolau staining, 2%. And peroxidase test, aniline blue, entologene blue, 2%. Correct answer is B, tunnel, SCSA, SCD, and COMET. A quick remark on the other ones. The aniline blue and chromomycin A3 are actually used for compaction analysis. Papa Nicolau staining is more used for morphology reading, and immunobeads is for anti-sperm antibodies. So we'll go ahead and move to the second question. Okay, so question number 2, which clinical interventions can be considered to alleviate infertility associated with elevated sperm DNA fragmentation? A, lifestyle modifications, including weight loss, quitting smoking, protein supplementation, and testosterone replacement therapy. B, antibiotics, oral antioxidants, and selective estrogen receptor modulators. C, varicocele repair, FSH therapy, use of testicular sperm in preference over ejaculated sperm in couples needing ICSI. And D, all of the above. So let's vote. So again, feel encouraged to use the Q&A box if you have any further questions on the coming presentations or the previous one. Okay, so here we have a majority choosing all of the above. D, 64% of participants. Second most voted was C. Correct answer is C. And a quick remark here, in option number A, letter A, testosterone replacement therapy is not advised for those men seeking fertility because it can inhibit the hypothalamic hypophyseal gonadal axis. And we don't have enough evidence or any evidence to use selective estrogen receptor modulators to decrease DNA fragmentation. So that's why C is the correct answer. Okay, so I think that wraps up the polling questions. I'll give the word back to Sandro, and so we can present the case study. Thank you.
Thank you very much, Ricardo, for that. It's interesting to see how people react to the polling questions. Now, this is my pleasure to introduce you to kind of explain the case study that you prepared. Ricardo is reproductive urologist, professor of urology of University of Campinas, and he did fellowship with me several years ago and became one of the critical, staff in our clinic looking to male infertility patients. So his clinical interests include andrological evaluation, varicocele microsurgical repair, microsurgical sperm retrieval techniques for ART. And he has also a strong publication record. And I am very happy that Ricardo is part of our team. Ricardo, I handle the session over back to you to present the clinical case. Thank you very much.
Well, thanks again, Sandro. I will present the first case study for us to discuss. This is actually a real case that we saw in clinic. Oops, sorry. Go back. Okay. So this is a young couple who presented for evaluation with a history of infertility and 2 previous first trimester abortion following spontaneous pregnancies. The male partner is 30 years old and his spouse is 36 years old. They have been married for 3.5 years now, and last pregnancy occurred more than 12 months ago. As of their infertility history, this is their first and only marriage for both. No use of contraception for the past 13 months. Female evaluation revealed normal gonads with an AMH of 1.3 and the 2 abortions previously mentioned. Regarding their sexual history, it's uneventful with a successful timed intercourse. Childhood and pubertal development were also uneventful. The patient is an engineer, and it's noteworthy that he has been taking some vitamins, including vitamin C, vitamin E, and folic acid for 1 month. And the only habit that merits a comment is that he's a former smoker who quit smoking 3 months ago. So at physical examination, he's overweight. He's a BMI of 35.3, weighing 224 pounds, which is 102 kilos. Both tests are topic, normal sized. There's no sign of clinical varicocele. Physical examination is pretty normal otherwise. So this patient comes to clinic with a recent seminal analysis, as we can see in this slide. Semen is actually pretty good, but this does have an elevated leucospermia, as you can see at the bottom of the screen, and a positive peroxidase test. Sperm DNA fragmentation is 27% for a normal value under 20% as measured by sperm chromatin dispersion test. So on the right side, you can see the reference range values for the 6th edition of the WHO publication. So in summary, we have a couple presenting with primary infertility with a history of true pregnancy losses, obesity, apparent normal zoospermia, elevated sperm DNA fragmentation, with this ovarian reserve of 1.3 measured by AMH. So there's no apparent female factor, but there is a borderline ovarian reserve. So what would be a suitable next step? So I believe we can do the pooling question on this one, right? If you could bring that up. Expectant management, timed intercourse. Number 2, IUI. Number 3, IVF. Number 4, full andrological evaluation. Number 5, I'm sorry, this is wrong, it's 3, but it's 5, I don't know. So let's give a few seconds for people to vote. All right, so we have the results here. Full andrological evaluation is the winner. It's 76%. IVFs 15%, IUI 7%, expected management timed intercourse 2%. Actually, for this one, there's no like right answer. There are options, but I'm glad to see that most of people decided to recur for to go after a full andrological evaluation, because that's exactly what we did. So I'll follow with my presentation here. So we did full andrological evaluation with the initial complete hormonal profile, bacterial triage of the semen, optimization of antioxidant therapy, and strong orientation for weight loss. So this is the lab work that the patient was submitted to. So you can see that the lab work is pretty unremarkable as follows. The patient does have normal gonadotropins values, a total testosterone level of 579, and the other hormones are pretty normal otherwise. Seminal culture revealed a positive culture for ureaplasma ureolyticum using PCR technique. And we decided to adjust antioxidant prescription. So previous prescription included vitamin C, E, and folic acid. We added zinc, selenium, coenzyme Q10, L-carnitine, and N-acetylcysteine. And the couple was treated with a 14-day course of broad-spectrum tetracycline antibiotic. We use doxycyclines, 100 milligrams, 2 times a day for 14 days. So here is the reassessment of the seminal analysis following 6 months after negative culture, after regular use of antioxidants, and after weight loss. The BMI came down to 29.6. Patient still overweight, but doing much better than he was previously. So we can see that the second collection, we also did a shorter abstinence from 3 to 1 day, but you can see that there was a normalization of the peroxidase test, which now we have 0.5 leukocyte, 0.5 million per ml leukocytes, and fragmentation dropped down to 13%, which is absolutely within the normal range. So this is what happened. So this was a recurrent first trimester miscarriage after natural pregnancy with a young couple, male partner with 30 years old, female partner 36 years old. So after a full andrological evaluation, we did some intervention in the lifestyle, added a full antioxidant therapy, directed a male accessory gland infection treatment, although it was an asymptomatic infection. And fortunately, we gave the chance for this couple to achieve natural pregnancy after 8 months of treatment. Pregnancy was uneventful, and the couple eventually gave birth to a full-term healthy baby boy. I think that's what I had to show you. Thank you very much again. I'll remind you guys to, if you have any questions regarding this case or the previous presentation, to use the Q&A box, and we'll try to address the questions sometime later on. I'll handle the session back to Sandro. Thank you very much.
Thank you very much, Ricardo. Very interesting case. I mean, I think the message was clear that we have the option to intervene. You did, the full andrological evaluation in which you included the semen analysis, the hormonal profile, the physical examination. You identified some factors that you could improve. And at the end of the day, the couple was able to, achieve natural pregnancy, delivery, without the need to go for assisted reproduction. We can avoid some cases. Obviously, many patients will need to undergo ART, but I think even in the case of ART, we could provide benefit by identifying these factors. Actually, we are intervening in the male germline, and we are improving the male germline. We have several questions now. We open now the session of questions and answers. We have about 10 minutes left for the questions and answer sessions. I see many questions in the chat. I thank you, all of you participating in the program, posting questions, and then I think we can display some of these questions, or I can read some of them. So we have question, specifically one question. Can you show us the procedure of sperm chromatin dispersion? Does it need any specific equipment? Well, the sperm chromatin dispersion test is simple. It can be implemented in the andrology lab using the equipment you have for the basic semen analysis. So you can use the bright field microscopy for evaluating the slides. The other thing is that the kits, usually the kits provided by the manufacturer are complete. So you have the staining, you have all the protocol, and also they provide the steps you need to do to run the positive and negative quality control. So for the SCD, there is no need actually to have specific equipment. More recently, we have some companies providing softwares in which you can measure the size of the halos. They can provide like the computer-assisted semen analysis also for sperm DNA fragmentation. I believe these systems still need some validation, but I feel that in near future, we will be able to assess also sperm DNA fragmentation using the computerized platforms that are available. But you can do it manually in your lab by implementing the test using the positive and negative controls and the kits provided by the manufacturer. No need to invest in expensive equipment. There's also a question about is sperm DNA fragmentation reliable variable to decide who may benefit from varicocelectomy? This is by Dr. Susanto from Indonesia. Thank you very much for this question. I think this is critical because according to the male infertility guidelines for varicocelectomy, varicocele is recommended most often in patients in which we feel the varicocele. This is a clinical, palpable varicocele that you can see is grade 3, that you can palpate using your hand without any Valsalva maneuver. This is grade 2, or you ask the patient to do the Valsalva maneuver and you feel the varicocele. This is grade 1. Grades 1, 2, and 3 varicoceles might be eligible for treatment provided the patient has abnormal semen analysis. But usually we talk about basic semen analysis according to the WHO. Now, if we have, let's say, a patient with borderline semen analysis results, or the results are within the normal reference range, and then you have elevated sperm DNA fragmentation, we believe, and we provide that information in the paper, the guideline that I comment on my talk, that we should consider varicocelectomy because there is a strong association between varicocele, and oxidative stress. Oxidative stress is critical in the pathophysiology of varicocele. So we could be able to identify certain patients in which the semen quality, according to the basic semen parameters, are not so deviated to the abnormal side, but the effect on the chromatin is already there. So I think, yes, we can be able to use the DFI as a variable to decide patients who might benefit from varicocelectomy. And we have done that routinely. There's another question that I can also ask Ricardo to make a comment. There's Dr. Barak from Israel, Shalom Barak. Thank you very much for joining us today, Shlomi. If you have tried to use aromatase inhibitors to reduce DNA fragmentation rather than FSH. So he's talking about use of medication for actually decreasing sperm DNA fragmentation. I would like to hear also your opinion on that, Ricardo.
Well, thanks for the question, Dr. Barak. I personally don't have any experience using aromatase inhibitors for that purpose. I do use aromatase inhibitors for hormonal therapy, especially when patients are hypogonad, and I feel that we can actually bring the testosterone up for stimulating sperm production. But I myself, I don't have any experience using aromatase inhibitors for the purpose of reducing DNA fragmentation. I don't know if you, Sandro, have any experience on that, but not myself.
Yeah, no, I'm not using aromatase inhibitors for that purpose. Along with that question, we have another question saying that, asking from Krilis Ivanovic, which patients do you mind should be candidates for FSH therapy in idiopathic infertility? I mean, we have, for instance, the data from Italy, in which they have been applied FSH therapy for male patients with FSH levels below 8, in which it's even covered by the government, I mean, the use of medication, and they have shown an increase in sperm quality and decrease in sperm DNA fragmentation. They have several publications specifically from the group of Manuela Simoni, Daniele Santi, showing that. So I think you might consider using in that particular category. In Brazil, for instance, because the medication is not provided by health insurance, we do not use it routinely. I prefer in patients refractory to treatment. I mean, we have provided the treatment using interventions, lifestyle modification, varicocelectomy, if applicable. We go for testicular sperm. And what we do actually, when we take specimens from the testicle, we always check for sperm DNA fragmentation. So we can check, we can analyze sperm DNA fragmentation in sperm. I will go back later to that because we have questions specifically on that point. And then, I mean, the sample used for ICSI, our experience has been that the specimens taken from the testicle, they systematically, consistently have lower sperm DNA fragmentation rates compared to ejaculated sperm. So this has been our experience. In patients in which I see that the sperm DNA fragmentation levels are still high in the testicular specimen and the couple fail ICSI cycle, and then I consider the FSH therapy. So the patients will go for, I prefer recombinant FSH given in a dose of 150 international units twice a week for at least 3 months. So, but this is the condition we are using at the moment. There's another question, Ricardo, that perhaps you can help me answer is how long should we use antibiotics for, I mean, in the case that you presented? So what is the protocol? And you mentioned the duration, but could you reinforce your answer again?
Yes. So usually when we face a male accessory gland infection, we give antibiotics. We treat the couple, that's one thing. And then we extend the treatment for 14 days minimum. And we usually reassess the culture 2 to 3 weeks after again to make sure that the infection is gone. And then we may consider that the start point, the time start point, to consider a normal semen. So that's what I usually do in practice.
So thank you very much. We have a question from Sebastian Voinea from Romania. Hello, Sebastian. Sebastian wants to ask if the tunnel tests show a very high fragmentation, for example, like over 70%. If it's a good idea to do go for the first IVF ICSI and not to wait for IVF ICSI to be failed. Absolutely. I think the message I would like to give is that, I mean, obviously, we have in our hands the procedures like IVF and ICSI. And ICSI is better than IVF in terms of sperm DNA fragmentation. We have data specifically from Denmark, in which they provide some seminal work in 2007, showing the difference in live birth rates when they use conventional IVF and ICSI in couples with elevated sperm DNA fragmentation. This is the group of Mona Bungun, also that Professor Peter Humayren participated, in which they showed the better results with ICSI. But the important point is that we need to decrease sperm DNA fragmentation rates, I believe, even before IVF ICSI. And there's a question here related to yours by Apostolos Tsironis. What is the use of sperm DNA fragmentation on a already abnormal sperm if ICSI is recommended anyway? Well, this is a very important point because they believe that, I mean, we can go for IVF and ICSI and then overcome sperm DNA fragmentation has to be analyzed critically. First of all, we have the data from the group of the University of Utah, Simon and co-workers that I presented in my talk, in which they showed that the odds ratio for live birth in pregnancies in couples with elevated sperm DNA fragmentation was significantly lower than, couples with normal. The odds ratio was 1.12, and you say, well, the difference is not very big. But then we need to analyze clinically and critically these results, because we know that the equation also affects the female partner. And we now know that the oocyte has the capacity up to a certain extent to repair some DNA breaks. So if the oocyte comes from a young patient, the chance of repairing DNA breaks will be increased. But our patient population that we see in the IVF clinics these days are not that young. In our clinic, for example, the average age is around 38 years old for the female partner. So in the patients we see, perhaps the patients you see as well, they are not so good or healthy to kind of repair the DNA breaks that we see in sperm. So I believe that if we have the opportunity to decrease sperm DNA fragmentation by interventions that last for 3-4 months, we are not actually impacting negatively the results of IVF ICSI. And in that sense, we have 2 very nice studies published in Human Reproduction this year after COVID, showing that the delay in treatment, because it was mandatory by the regulatory societies in several countries to stop treatment during the COVID pandemic, especially in the beginning. So this study showed that the delay in 6 months were not actually affecting negatively the chances of pregnancies by IVF and ICSI. So translating this information to our field, male infertility, in which we could provide this andrological evaluation and then intervene in terms of with the interventions that we showed that could decrease sperm DNA fragmentation, we could actually avoid miscarriages and also ICSI failure. So I think even if the specimen is already abnormal and ICSI is recommended anyway, I believe that the assessment of sperm DNA fragmentation, for me as a clinician, it will guide me to kind of assess the couple properly to see what I can do to help. So we have also another questions. We are just finishing. I will just go through questions that are related to the assessment of intratesticular sperm. This is João Paulo Camarso. Thank you very much, João Paulo, for joining us today. And also related to that, we have other colleagues asking the same thing. And they are talking about the assessment of intratesticular sperm using DNA fragmentation test. We can do it. We are doing with the sperm chromatin dispersion test. This can be applied using the bright field microscopy or with the fluorescence microscopy, and this can be easily done. The limitation will be the sample size. I mean, if you have very few sperm, like severe oligospermia, that would be more challenging to have enough sperm for evaluation. But usually these patients, they have moderate oligospermia. Sometimes they are normal zoospermic. So the limitation is if you have a severe oligospermic patients. And the question also interesting that comes along with that is from Dr. Pragasta. For instance, what technique we can use to evaluate the sperm DNA fragmentation in sperm, and afterwards the sperm is still viable to be used for ICSI. Well, using these techniques I showed you, the 4 techniques, we are not able to use the sperm for ICSI, okay? We need, because they use staining techniques, they use flow cytometry, but they incorporate stain, fluorochromes, or other stains. So it's not possible actually to use that sperm evaluated for ICSI or IVF or IUI. Now we have the microfluidic devices that are taking, I mean, we are having more and more studies on the microfluidic device that have been shown to decrease sperm DNA fragmentation rates. So the idea is that whatever you do, an intervention, testicular sperm, or applying microfluidics to have a specimen with lower sperm DNA fragmentation rates, is that the specimen you are working with is better. I mean, the chances of using sperm not affected by DNA fragmentation will be higher. And then you increase the probability of pregnancy. But we cannot, at the moment, kind of completely rely on a technique, an assay that could say, okay, I did the assessment, the sperm is normal concerning chromatin integrity, and I'm using that for ICSI. Well, we have several other questions. I see that the questions are coming and coming. We have also Professor Pedro Xavier. Thank you very much for joining us today. Pedro is president of the Portuguese Society of Reproductive Medicine. He wants to know, we have good results in couples with recurrent implantation failure by going directly to ICSI with testicular aspiration, even with normal sperm DNA fragmentation tests. Could you comment on that? Yeah, I mean, you presented a very interesting paper recently showing good results by your group in Portugal related to that. I believe that, I mean, we need to explore the possibilities. We are using a testicular sperm for ICSI most often in couples in which we confirm the elevated sperm DNA fragmentation rates. I know other groups are showing different results, I mean, concerning the possible benefit in patients with cryptozoospermia, and even, I mean, after ICSI failure, going directly to testicular sperm, which is very interesting. I think this is something that we need to expand and evaluate what kind of population is most often benefit for testicular sperm for ICSI. Well, I would like to move on because time is running fast. This is now my pleasure to invite Professor George Halak to the stage. George is, besides being a good friend of mine for several years, we did our fellowship at the Cleveland Clinic, not at the same time, but I mean, we have been there around the same period. George is Associate Professor of Medicine and Coordinator of the Reproductive Toxicology Unit at Department of Pathology, University of São Paulo Medical School. Jorge is a renowned Brazilian urologist specialized in andrology and male infertility. He has great experience in microsurgery. He is also an expert in advanced andrology laboratory and sperm cryopreservation. And very important, as I said before, during the COVID pandemic, Jorge and his group conducted a series of studies looking into the impact of the disease on male reproductive and sexual function, some of which gained a lot of attention even in the media. So thank you very much, Jorge, for joining us today from São Paulo. And the floor is yours. Thanks a lot.
Well, first I'd like to thank the organizing committee and Sandro Esteves, who's been a very good friend for decades now. And I'd like to salute the organizing people from Medea for this excellent opportunity to share some of our research on COVID-19 male reproductive health. Can you use my slides, please? First of all, the whole lecture is on the website. For this is a short version. Please, so I welcome you to join the full lecture platform in the website, which will give you substantial more information than just this resume. But anyway, please feel free to contact me by any other means necessary, even for after the lecture, by email or by any other way you find necessary for anything that happens to occur for this presentation. Well, I'd like to start by showing a paper that we just published recently, a few months ago. It's known that male sex is more prone to death tolls and more severe disease in many viral bacterial infections. And that is commonly related to the fact that men go less often to see doctors. They don't take care of preventative medicine. They take less care of their health. And we like to check that on the COVID-19 because in our hospital, which is the biggest hospital in Latin America, we had 1,500 beds just for COVID-19 during the start of the pandemic. And as you know, the whole world stopped. We decided to look at the 2020 death toll in the city of São Paulo, which is 22 million city. It's a biopsy of the whole world. We have all socioeconomic variables. We have all kinds of social classes living here. So it's kind of if you have the whole world in a city. And we tried to look at the death toll before the P1 Amazon variant, which was highly infected. So we decided to look at more than 40,000 people that are died, and the recovery rate 71%, but the death toll was almost 30% in the early stage of the pandemic. And we decided to determine the whole of the male sex as a risk factor for coronavirus disease in the city of São Paulo, and also to look at the socioeconomic vulnerability and individual health issues can interfere with such risk, because these are the variables that everybody has said that could interfere more than the male sex for not just for this disease, but for men's health in general. So we look at almost 1,500 individual socioeconomic areas in the city of São Paulo, which was a cross between human development units, and we geocoded these areas according to Google Maps, and assigned this index as high, medium, and low, using urban infrastructure, human capital, income, and labor. And we look at many, many variables, 9 models of regressive, logistic regressive models using sex, age, people who went to intensive care units, obesity, renal disease, heart disease, diabetes, low social vulnerability index, medium and high, and etc. And by looking at all these variables, the only issue that was really related to the increased death toll for male was male sex. Even for patients with all the comorbidities, as you can see here in the models, they didn't present a higher death toll than women did, including low, medium, and high social vulnerability index, which of course impacted the death toll, but didn't impact the difference between male and female in the death. Therefore, the higher male to female death toll is rated in São Paulo. These findings could not be exclusively attributable to socioeconomic, behavioral, cultural status, nor underlying comorbidities and social vulnerability status. So the most critical determinant factors for severe outcome and death by COVID-19, such as comorbidities, incidents during different periods of the pandemic, and socioeconomic vulnerability, this cannot explain excess male deaths. This is very important for us that we are looking at men's health for andrology, and we people specialized in taking care of the male. So biological factors seem crucial to explain these findings of increased frailty of COVID-19, and this should promote future research and guide public policies. And it's not just because men don't go to see doctor very often. As you know, Dr. Swan and the collaborators, they just released another version of this impactful paper, and they saw a 59% decline in total motile sperm count over the last decades, and that should be seen as a warning sign. So that's why we should look at men's health in general, like Sandro said. We should have a comprehensive view of men's health. And I believe, due to our studies and others, that COVID-19 came to be one more problem in the male evaluation, reproductive and sexual health issue, besides everything that was said in the previous lecture. Of course, in the beginning of the pandemic, you did this nice paper published in Andrology. We already knew that we were already conducting some studies in people who were deceased, and we saw that the testicle was highly affected by the SARS-CoV virus, and not just the testicle, every single compartment of the testis is affected, and the epididymis as well. So, of course, we have the ACE2 receptors, which attach to the spike protein of the virus, but not just that. You must have a promoting protein. Without that, you don't have the infection as well. So you must have two proteins, the ACE2 receptor and the TMPRS22 as a promoting for this binding to occur. And that happens to exist in the testis, but not in the ovary. So that is some way to explain why the male sex is more prone to disease severity and death than the female counterpart. That may be one of the reasons. And then we also did a nice public paper. We looked at viral infections and saw the 27 viruses that affect male reproductive health. And in the beginning of the pandemic, you see there is not much information available for the SARS-CoV, original SARS-CoV-1, which happened in 2003, and this SARS-CoV-2 infection, which happened less than 2 decades later in 2019. So we had to look at the brain, and every time I don't have answers in the tests, I go to study neurology, brain physiology, and this paper demonstrates that there is a lot of proteomes, a lot of proteins, a lot of intersection between the neuron and the sperm cell, between the brain and the testes. So every time you don't have an answer in andrology, please go and study the brain. You find some answers. The both organs they share a lot in common. And then we look at the patients who are hospitalized, not intensive care units, but just patients who need some medical, like oxygen therapy, some corticoid therapy, mild to moderate and severe COVID infection. And we found hitherto, the first time in the literature, we found epididymitis, subclinical epididymitis. I mean, all these testicles were examined by experienced urologists, and none of them had clinical epididymitis, none of them had clinical orchitis. We found more than 42% of subclinical epididymitis on testicular Doppler ultrasound in hospitalized patients with moderate COVID-19 infection. And more than that, we saw more than 54% enlarged epididymal head. We described it for the first time, two different patterns of subclinical epididymitis that are different than bacterial epididymitis, that are different than mumps, orchitis, or other viral infections. This has been published in 2021, and we saw, as you can see here, an inhomogeneous echogenicity with increased Doppler blood flow. We see some micro abscess just in the epididymal head, not in the entire epidydymos, and some edema and thickness of the scrotal wall. We also identified the second pattern of subclinical epididymitis in SARS-CoV-2, of course, with some hydrocele, some thickness of the blood wall as well, some reaction hydrocele, and the pattern is very different from the classic bacterial that we see often. Then we moved on to see our one of the papers that received a great impact. It was the front cover from Andrology for 2022 in January, and we look at patients who have had deceased from fatal COVID-19, and we saw that interstitial orchitis was present in more than 85% of the patients who had a fatal outcome, with interstitial edema and disarrangement of Leydig cells, severe disarrangement of Leydig cells. You see thrombi in the artery, atrophic tubules, and you see a lot of atrophic tubules in this is a 45-year-old man with only 20 days of disease duration. He was a previous father of 2 children. So you can see that very quickly the disease caused some very nasty testicular damage. And also you see it there, we look at the expression of AC2 and T, and also the protein, the promoter protein, the testes and ready testes. You see that the beginning of the pandemic, these individuals were all wrapped in plastic. It was a level 4 contamination protocol. We had to use to biopsy these testes using fine needle aspiration. So we couldn't exactly, through the plastic that these bodies were wrapped, we couldn't find the epididymis very easily. Everybody who was in this protocol got COVID-19 infection in the beginning, including myself. So the expression of AC2 is in Sertoli cells, somatogonia, fibroblasts, and Leydig cells in young adults with preserved tubules, and also in the atrophic tubules you see the same expression. So you can see that the testis is there. There's all the elements for entrance of the virus in the circulation. And also we look at the SARS-CoV-2 end protein and the particle detection. Not everybody looks at the spike protein. We look at the end protein as well. And you can see the end protein is there in this fatal COVID-19 patients. You see the fibrotic thickening of the basal membrane. So the basal membrane is severely thickened by Mason's trichrome. You can see the area of disarrangement of this basal membrane, and you see also the fibroblasts, Leydig cells, circulating cells, somatogonia, they're all affected, severely affected by the N protein as well of the SARS of the virus. And we move it on to see testicular electron microscopy in this, and the virus is there as well. You can see clear the virus. You see the spike protein, the viral envelope, the nucleocapsids, and the viral particles are all over the cell types that I have mentioned before, including lipids, including collagen fibrils, including the plastic reticulum, including the cell nucleus, including actin filaments, everywhere. You can see here also, there is a huge inflammatory infiltrate in huge orchitis in these patients that sometimes is not clinically seen, even in more severe cases. You see, there are very few reports of orchitis in the literature. You can see in the fingers of one hand the paper that's been related for orchitis only. But if you go for the pathology, the orchitis is there in a subclinical pattern, but it will disrupt spermatogenesis and may cause hypogonadism, as you can see later in this presentation. Then we tried to do some experiments looking at the nucleocapsid protein, not just at the spike protein. So we decided to go to the lab, to the experimental animals, and look at the N protein because N protein is a potential candidate for vaccines due to genomic stability, homogeneity of amino acids within the beta coronavirus family. It promotes a high immune response, activating T lymphocytes and antibodies. So our objectives here was to test the safety of a future vaccine based on N protein for male reproduction, and to check all compartments by injecting only N protein. And we decided the full lecture is available on the website, so please go in there and check. You can see that we found difference in testosterone levels between the experimental animals that were injected only with N protein. See substantial decrease in testosterone levels and free testosterone between the controls and the animals in the lab that were injected by this protein. So the conclusion is that may cause hypogonadism. And this study, this is not my study, this is a nice study that was published recently as well. You can see the intranasal inoculation of SARS-CoV-2 in the tests in the chronic phase. You cause decrease in sperm count, testosterone, but that is later. So don't expect sometimes immediately that the patients present a drop in sperm count, motility, which does happen often in the clinic scenario, but that is a prolonged effect that may be later after the infection. Like the radiotherapy, those who do radiotherapy for seminoma, etc., see a decrease in testosterone level that is chronic. It may take some months. So you can see here 42 days post-infection and even 120 days post-infection, a decrease in sperm count and hormonal levels. Also, the testicular has some atrophy in comparison to age mock controls, also decreased testicular weight after 120 days post-infection, across presenting a chronic progressive testicular damage in these golden Syrian hemispheres. And then you can see even in the early phase of infection, if you increase the plaque forming units, if you increase the viral load, you can have a more recent degree of inflammatory damage in the testis. So that demonstrates to us that may be a relation to the viral upload, to the viral intensity, to how many the viral that was really infected that man, if it was a low disease or a mild disease. So the SARS-CoV-2 can cause acute testicular damage with chronic asymmetric testicular atrophy and some hormonal changes. In despite of a self-limiting pneumonia or clinical scenario in these hemispheres. And this is our awareness for possible hypogonadism and subfertility in the convalescence phase of this man. We look at also at the sexual part for doctors and in our hostel, and we saw a worsening of sexual satisfaction in 44% of the participants, worsening of libido in 37% of doctors that were evaluated in our hostel. And the problem is that WHO 2021, now going to the sperm part of the lecture, you see the 50% percentile does not really mean that's the lower level of normality. That should not even be looked at as normality, because if you see just 5% of these men could establish a natural pregnancy in 12 months of sexual unprotected intercourse, I don't think that nobody does that this should be looked at the lower level of normality. So please carefully look at the WHO 2021. If you go for the 50% percentile, the sperm concentration should be around 60 million. You see that's much higher, much more, the numbers here express much more reliable the real condition for normal reproductive capacity. You know that, like the previous lecture has stressed, that oxidative stress and sperm membrane lipid peroxidations are in the majority of the cases of the causes for male infertility. You see the sperm membrane has over 50% GHA, which is very prone to lipid peroxidation, lipid radicals, and to these reactive aldehydes that will produce ultimately DNA damage. But don't expect DNA damage to look at the infertility. Sometimes you must have a high level of reactive species, a high level of lipid peroxidation, and the DNA is relatively preserved. That does not mean that the male is fertile. So these sperm cell membranes are highly vulnerable to ROS attack. We presented at the AUA this year as an oral presentation that elevated ROS and DNA fragmentation sperm from convalescent men. And what we found was that the concentration in total motile sperm count were reduced in the COVID-19 group of patients. We demonstrated normal morphology both from WHO criteria and from strict criteria, were also reduced, as well as progressive motility. And DNA fragmentation was extremely high. But the question here is, DNA fragmentation was extremely high, but the ROS generation was not that high. In fact, ROS was not statistically significantly higher than the control group. And also, lipid peroxidation was not there. So for COVID-19 in particular, the mantra that we say that oxidative stress is the main cause for sperm lesion may be not the case in COVID-19 disease. And then we move it to these very impactful results, which are going to be published hopefully within the next 6 months. This is not published yet, but has been presented at the American Urological Association as a presentation this year as well. By electron microscopy, we hitherto, for the first time in the literature, we demonstrated the massive presence of intracellular SARS-CoV-2 viral in the spermatozoa. And also it described the mechanism was the sperm cell lesion, which is not related as with reactive oxidation species, like I said before. It's a direct effect of the viral in the sperm cell. And we saw some extracellular traps in a cfDNA-dependent manner, like this described for other types of cells in the COVID-19 pandemic. And we saw in 9 of 13 patients up to 90 days after discharge from the hospital, which makes 100 to 110 days after initial infection, these patients still present the virus inside the spermatozoa. And that is very worrying because we published it with Sandro and early in the pandemic that andrological service should not be available for oncological patients, but also for time-sensitive patients. But now I would change a little bit this paper by waiting for 6 months after any kind of SARS-CoV-2 infection before proceeding to any type of andrological treatment that interferes cryopreservation, that requires cryopreservation, or any type of assisted reproductive technology. That is new, but I believe that that's something that we have to check from now on. As you can see, this very worry slides. You see the spermatozoa to go, see paternal age, all the things that have previously been pointed in the previous lecture. They maybe have some impact on centrosome fertilization process and initial embryonic development. And now I would humbly include the SARS-CoV-2 here. That can change the mutation load and the embryo. So I would add to this last sentence here, SARS-CoV-2 infection, recent SARS-CoV-2 infection. As you can see here, human pre-implantation embryos are permissive to SARS-CoV-2 entry. So if you buy ICSI, by natural conception, it's very unlikely that this spermatozoa reach the fallopian tubes and can still fertilize the egg. But by ICSI, when a single spermatozoa is injected into the oocyte, if the spermatozoa has SARS-CoV-2 virus inside, which is not seen by the embryologist's eyes, including some marketed techniques that use increased augmentation to see the size of the spermatozoa, which in my opinion is much more for marketing purpose than for really increasing ICSI results. You can see that the embryos is permissive, and you can result in embryos that can be infected by SARS-CoV-2, and this has serious implications for assisted reproductive technology, which is basic. We all understand, we all are very pleased to have this in our arsenal, the in vitro fertilization, IVF, and ICSI techniques, which for us is very important for the severe male reproductive, severe case of male infertility. But we must be very careful on the indications, like it has been pointed in this nice morning that we are here. We must do a full andrological evaluation and treat the male before proceeding to IVF and ICSI. And we believe that the call for more responsible use of assisted reproductive technologies, this paper was published in 2017. And I believe that the hidden consequences of abuse, lack of andrological investigation and inaction, this was before the COVID-19 pandemic, now is even further. This has more serious implications. As you can see, andrology can turn this spermatozoa with 76% DNA fragmentation and 6 previous ICSI failures into this spermatozoa with still 37% DNA fragmentation and a normal delivery through ICSI. So ICSI is welcome in andrology, is more than welcome in andrology, at the right time, at the right momentum. Thank you very much for your time.
Thank you very much, George. Very informative. talk with a lot of information. It shows how your group has been so productive during this period with several impactful papers, and we are very, very happy that you are, I mean, so active in the academic field and also clinically. And thank you very much for your excellent presentation. Now I move to the polling questions. We have 2 polling questions for you. We can go now for that. I will ask the participants to start posting questions in the Q&A. The questions that we are not able to answer live, I'm trying to answer, and we will type some of the answers. And for other questions that we are not able because lack of time, we will then later post the answers in the Medea platform. Specifically for this program, you see the answers in that part. So regarding COVID-19 infection and men's health, which is correct? A, higher frequency of fatal outcomes for men compared with women are related to comorbidities and risk factors like diabetes, hypertension, obesity, and renal diseases. B, men in a lower socioeconomic status are more prone to have a fatal outcome than their female counterparts within the same conditions. C, men die more because they do not go to check for their health like women do not exercise as well, and have an unhealthier lifestyle. And D, the male sex is the only variable that determines higher male to female risk for dying of COVID. So please vote. There's only one correct answer. So you will have some seconds to post your answer in the box. Please do it. Thank you. So we have here, I mean, they split. I think 44% of the participants answer D, which is the correct answer. And that was stressed during Professor Halak's talk. I think we will move to the second question. Then during the discussion, he can emphasize a little bit more if needed, the issue of the male sex. So the other question is regarding COVID-19, no, this is pathological and radiological studies in patients with SARS-CoV-2 that developed mild to moderate disease. Reveal that A, clinical orchitis and painful scrotum are often reported. B, clinical epididymitis is more common than orchitis and is easily discovered by an experienced clinician during physical examination. C, color Doppler ultrasound reveals the same pattern as mumps orchitis, and the consequences are the same as in other viral infections. D, in fatal COVID-19 cases, pathology reveals interstitial orchitis, Leydig cell disarrangement, interstitial edema and inflammation, atrophic seminiferous tubules, and fibrin thrombus within testicular vessels. And lastly, E, the only testicular compartment affected by the SARS-CoV-2 is the interstitium. All other cell types are preserved. Please post your answer. There's only one correct answer. Yeah, I think most people actually got it right. D is the right one as presented by George during his presentation. Thank you very much for posting your answers. Now we open for the questions and answers related to the talk of Professor Halak. We have many questions already coming up. There is one question by Eva Kachanova. I hope I spelled it correctly. So thank you for the great presentation. Did you find any correlation between the severity of the SARS-CoV-19 infection and the testicular damage, hormonal, and impaired spermatogenesis and hormonal levels?
Well, thank you for the nice question. The issue is that the point is that the most severe diseases, this patient that go to the intensive care unit, they are prone to have more severe damage in the testes. But the intriguing part is that patients that even with mild, really mild COVID-19 infection, they may present basically with lower testosterone levels. And basic sperm parameters, even if they don't change too much, if you go into the more sophisticated functional tests like reactive oxygen species, 8-hydroxyguanosine, lipid peroxidation, even CK, which is creatine kinase, which measures sperm immaturity and DNA damage, you'll be surprised by finding that even in the mild cases, they may present with increased levels of DNA damage, mainly DNA damage in comparison to reactive oxygen species and lipid peroxidation. But we did see in the most severe cases, particularly patients who have had pulmonary thrombosis, some high degrees of lung affection. These patients, they're more impacted. The tests are more impacted, and they may take more time to recover, or even don't recover the hormonal previous pre-infection hormonal levels. Very often I see patients with present in the clinic with low testosterone levels. I'd say 180, 190, 130. Some young patients who were my patients before they had infection, and they had with us the same lab testosterone levels up to 500, 550, 450, and then now after infection they come to the office complaining of lethargy. They feel tired. They don't sleep at night. They don't feel good to work. And we check the hormones, they are very low. So I believe that this disease is still an enigma for men's health and andrology and urology, because people are looking at the long COVID syndrome to other parts of the body, but they don't really connect the clinical symptoms of the patients to the reproductive and sexual organs. That's a problem, because everybody's concerned about the memory issues, pulmonary issues, cardiovascular issues, and that the real part that may be impacting these other organs to function well are the testicles, which are not functioning well. So my answer to you is yes, but don't downsize, don't downlook at patients with less severe disease.
So George, I think this is nice that we follow up with your clinical case, because then you can highlight some of the points that we discuss, and then we continue if you have more questions. So I'd like you to share the clinical case you have brought to the discussion. Thank you.
Just my slides, please. Okay. Okay, this is a nice case, I believe that many of your doubts will be answered here. This is a patient 35 years old with light flu-like symptoms. Date of onset July to 10, 2020. So the first wave of COVID-19 disease. He had a fever, not very high fever, dry cough and asthenia. It's a moderate severe evolution, orotracheal intubation, ICU. We stay for 2 weeks. Respiratory part involved satisfactory, and he was discharged after 2 weeks of hospitalization. RT-PCR positive for SARS-CoV-2, a little obesity, BMI 30, no other comorbidities. Previous medical history was uneventful. Bilateral VAS, no varicocele, no hydrocele, and the pressure oximeter 10 ml, testicular volume, normal physical examination with, I would say, little hypertrophic testicles in the physical examination. I don't believe 10 ml is normal. And the Doppler ultrasound revealed around the same testicular size. And the question is bilateral epididymitis detected by Doppler ultrasound, of course, asymptomatic, like I said before. His total testosterone levels were low. And this is I bring this case because this is more or less the most common testosterone levels that I see in patients post-COVID. They may go from 130 to 2000 to 230, but 180 is around common what I see post-COVID. As you can see, LH is not high elevated, not FSH, and it's really something that happened in the testes. Testicular seminal analysis showed some yellowish color in the macroscopic evaluation. Sperm concentration was 26 per ml, so according to WHO is normal. Total sperm count was very high, but look at progressive motility is very, very low in comparison to a patient that ejaculates 169 million sperm. Total motility with grade A, B, and C, 7%, and a very high percentage of immotile spermatozoa. You see a high amount of round Z cells without positive ENS tests, without positive peroxidase positive cells. So this is likely to be immature spermatozoa being ejaculated. We did some Ross assays using the gold standard, which is a chemiluminescence assay. Use of negative controls, positive controls, like all tests should be done. Without positive, negative controls, these tests are really meaningless. And see the Ross level was high. Normal levels without leukocytes, 0.55. And here with leukocytes, less than 1.25 times 4 counts per minute by 20 times 10 to 6 spermatozoa. So you see that the Ross in the whole semen was high, but the Ross in the washed semen was not so high, meaning that the majority of the Ross didn't come from intracellular Ross generation by the spermatozoa. As you know, the most of the Ross comes from the mitochondria, which is intracellular generated. Here you can see that the Ross is not intracellularly generated, it's extracellular generated. So maybe some metabolic Ross activity by the Ross that is in the body, in the seminal plasma. And if you use a CK assay, which is very, I use a lot to see sperm immaturity, which is very, very common in varicocele. It's one of the functional tests that you can use to check if the varicocele is really acting. It's very reliable when done properly. It's very easily done to check for sperm immaturity. As you can see, the COVID-19 is one of the few cases that you have increased CK analysis other than varicocele. as accordingly to the ROS level in the washed semen, which is compatible to this low lipid peroxidation by T-bars, by checked malonaldehyde, and by 2-barbituric acid, you see a low level of lipid peroxidation. Everybody remembers the Game of Thrones when the catapults launched those balls with fire, and that reached the castle wall. So the fireballs are like the reactive oxygen species, and the T-bars, the peroxidation, is like the castle wall resisting to the attack of the reactive oxygen species. So you see here that the T-bars is low, meaning that there is not really a direct impact of oxidative stress and lipid peroxidation in the pathophysiology of this spermatozoa lesion. But you can see a high DFI, which is usually courses with high reactive oxygen species and high lipid peroxidation. Not here. Interesting, you see a very high DFI we use the gold standard by Evanson, the SCSA. We have the authorization to use SCSA in Latin America. So DFI is very high. And also you can see in the mitochondria a high percentage of inactive mitochondria, which it means by DAP3 and DAP4. Also meaning that these mitochondria are not active in the spermatozoa by direct lesion of the virus. In fact, we have electron microscopy that's going to be published demonstrating a high impactful, incredibly normal virus in the spermatozoa. So this is the first case that I tried to show to you, that if you look at the basic semen analysis, you won't find too much. You need to move further to more impactful sperm functional tests to really understand what's going on with the spermatozoa from COVID-19 infected men.
Thank you very much, George. It was interesting case, and also highlighting the full spectrum of the sperm functional testing platform that we can, implement in the andrology lab. You have a very sophisticated andrology lab in São Paulo, which I congratulate you for that. We have time for perhaps one question only before we move to the last session. I think we have some sounds from the background of someone. Okay, so there's a question for you, George, that they're saying from clinical experience, from a doctor here posting a question. I have noticed that patients who have gone through the disease twice have a much more affected spermogram compared to those who have gone through the infection only once. Example, the British strain, then about 6 months after the Delta variant, and the recovery seems to be longer. So what are your thoughts on that?
Well, I agree. The patients I have seen with 2 or 3 times the infection, even after post-vaccination, which is very common now, they are still getting COVID-19 infection. And sometimes they don't even recover from the first infection. The point is that we don't have the previous semen analysis and the previous hormonal evaluation before the first infection or after the first infection. So that makes us difficult to in a scientific way, to understand and to really verify this point. But my impression from the clinical perspective is exactly the same. There are some patients who have had 2 or 3 infections of COVID-19, and they present now with real infertility and real low testosterone levels. And what I can tell you is that the patients that have just followed up from the first infection, the average time to recover testosterone levels not to the level before the pandemic was here. As I said, we don't have the pre-infection levels, but those who have is 20 months. So don't expect 6 to 8 months to recover hormonal levels. Sometimes it may take 14, 18, 20 months to recover. So you advise patients for a longer recovery time than expected.
Well, thank you very much, George. Just a follow-up question, and this is going to be the last one before we move to the last part of this live session. So someone is asking if you know some case of pregnancy during the COVID-19 infection in men that resulted on child disease or some problem with the children. You have any data on that or any thoughts specifically?
Nobody has. I just looked at the NIH and the CDC website last week, and the data they are presenting now is from 2019. So I believe that we don't have. That's a problem. We don't have from the IVF community, the fertilization societies, the number of abortions, if it's higher by IVF ICSI during the pandemic in IVF labs around the globe. I look at every single society. I couldn't find a paper or I couldn't find official numbers from American Society of Reproductive Medicine, the ASHRI or others, saying how was the behavior of IVF labs after the pandemic, if there has increased abortion, etc. So that's a missing gap in information that must be answered. And I believe that it should have already been answered, because now we are entering the third year of the disease, and data from 2020 should be available, and it's not.
Thank you very much, George. We move to the next part, but please stay with us. We want to have you commenting also some of the clinical case that our group prepared to present today. Now it's my pleasure to invite Marina Viana. Dr. Viana is a Brazilian urologist who graduated from the University of Campinas, Unicamp. During her senior residency year, she rotated at Androfert. Actually, she fell in love with the area of male reproductive health. She's currently a fellow in male infertility and reproductive medicine at the Federal University of São Paulo, Unifesp. And after completing her fellowship training, she will join Androfert as a staff member. So welcome, Marina, to the preceptorship, and please share your case with us.
Thank you very much, Dr. Sandro, for the amazing opportunity. It's a pleasure to be here today. So good morning or good afternoon, everybody. First, I would like to thank Sydney, our senior embryologist, and Maria Gabriela, our lab embryologist, for helping me with this case study, which is a real one and a very nice one. So let's move. The female partner is a 37-year-old woman, eumenorrheic, nulliparous, with no remarkable findings on history and physical examination, normal ovarian reserve for AFC and AMH. The male partner, a 40-year-old man with hypothyroidism and a background of treated STD. He already had a varicocele repair in 2021 with a macroscopic approach, currently using levothyroxine and a previously use of clomiphene citrate. No social habits, denies using tobacco, alcohol, or drugs, and he was an engineer. They were trying to conceive for about 3 years now and had a background of a failed ICSI cycle in an external service at 2021, where she had 8 oocytes retrieved with only 3 fertilized with a rate of 37.5%, 2 embryos developed with a poor development, and a fresh embryo transferred with a negative result. So about him, he had a BMI of 30, a left varicocele grade 2 and a right subclinical varicocele, testes and epididymis, vas deferens, everything was normal. Urinary tract ultrasound, normal. In the scrotal ultrasound, we have seen a recurrent left varicocele corroborating with our nose light. I saw someone sending here on the chat, nose light. Everything is okay with the slides for you guys? Yes? Can I move on? Good. So in the scrotal ultrasound, we saw the recurrent left varicocele corroborating with our physical examination. For the hormonal panel, there was nothing remarkable. FSH, LH, estradiol, testosterone levels was everything normal. And in the semen analysis, the first one was collected in March 2022 with a 3 days abstinence, a normal volume, but a concentration a little bit below the 5% threshold, and progressive motility of 11%, vitality 43%, and 0% of normal forms. The sperm concentration density was 35%, corroborating with a elevated DNA fragmentation. So we collected a second sample in May 2022 with a shorter abstinence of 1 day after frequent ejaculation. Sorry, I was looking at the chat. So the second sample was collected after frequent ejaculation, changing in the lifestyle of this patient, and oral antioxidants. Then we had a concentration of 12 millions, much better progressive motility of 49%, but still 0% of normal forms. And as we can see, the DNA fragmentation was 18%, showing us that frequent ejaculation and lifestyle modifications combined with oral antioxidants can bring us better results. And here we have the problem with the normal forms. We have a patient with 100% globosospermic sperm. We can see at the right side of your screen, the round-headed sperm. Next, here we can see the sperm chromatin dispersion test, where the red arrow, it's the fragmented ones, while the black arrow are the ones normal. We can see the halo around them. Moving forward, for this case, we have a total globosospermia, a background of failed ICSI with low fertilization and poor embryo development. We also have a recurrent varicocele. And at this point, I would like to ask you, what would you do for this couple? A, donor sperm. B, redo the varicocele repair with a microscopic approach, then ICSI later. C, repeat conventional ICSI. D, ICSI with oocyte activation. Or E, I don't know. I think we can do the pool now. So what do you guys think? Is everybody seeing the pool? Yes. So donor sperm, redo the varicocele, repeat conventional ICSI, ICSI with oocyte activation, or E, I don't know what to do now. You have 15 seconds to answer the pooling. And then, right, so 54% chose redo varicocele repair, then ICSI later. Right, so let's see what we've done at Androfert. So the ovarian stimulation was done by cycloprogramming with GnRH antagonist protocol with cetrotide, plus recombinant FSH and recombinant LH in the proportion of 2:1 for 10 days. Then we had retrieved 25 M2 oocytes. And for him, we asked the patient to have a short abstinence plus frequent ejaculation. And the volume we got after gradient centrifugation was 2.5 ml and the concentration of 19 millions and a progressive motility of 18. We also did testicular sperm aspiration, thinking about a lower rate of DNA fragmentation. And then we did sperm and oocyte activation. So here in the right side of your screen, you can see the big round-headed sperm in the inverted microscope. Here you can see the lab procedure. So first, before ICSI, we did the sperm hyperactivation after the conventional sperm selection by swim-up gradient centrifugation or sperm wash. The post-proceed specimen was mixed with pentoxifilin, thinking about hyperactivation of this sperm. Then we followed to the oocyte activation using calcium ionophore. The calcium was used because it will stimulate the waves that are absent due to the absence of the acrosome vesicle. Those are the 4 steps we did in the lab, thinking about the oocyte activation. We did 8 minutes incubation inside the calcium ionophore, followed by 8 minutes resting outside it, then followed again by 8 minutes incubation. And we ended with oocyte washing in the culture media, and then complete a conventional embryo culturing benchtop incubator. So here we have the table we see, our couple Cs, that's our clinicist, the system we use. The first column, it's about the oocytes. Second column about the sperm. Third column is about the fertilization. Then we have the 3rd, the 5th, and the 6th days following the development of the blastocyst. And in green, we can see the top quality blastocyst. In yellow, we can see the good, medium quality blastocyst. And in red, the not so good quality. So we had 29 oocytes retrieved. 25 of them were M2 oocytes. 24 were fertilized, 12 with ejaculated sperm, and 12 with testicular sperm. And the final result was 11 blastocysts developed. Here we have the image of all the embryos. We have 5 with ejaculated sperm, 4 were vitrified, and 1 was transferred. And then we have other 6 blastocysts with testicular sperm, which was vitrified. And I bet you are all very curious to know the outcome of this amazing case. And here we have the outcome. We have a 20 weeks ongoing pregnancy. And just to finish our case, there's a very quickly overview in globosospermia, which is a rare sperm morphology disorder, which affects 0.1 to 0.8% of men worldwide. And it consists in the presence of a round-headed spermatozoa in the ejaculated with a small vesicle, acrosome vesicle, or total absence of the acrosome vesicle, which can be very associated with cytoskeleton defects. We have 2 types of globosospermia. The type 1 is the type of our patient in this study case with total globosospermia, and the type 2, it's just partial globosospermia. The pathogenesis for this is still very obscure, but what we know is that globosospermia men have poor outcomes in conventional ICSI, and mainly for 3 reasons. Firstly, oocyte activation factor is inhibited or missing due to the absence of the acrosome vesicle. Secondly, due to poor sperm chromatin condensation and high levels of sperm DNA fragmentation in those men with globosospermia. And thirdly, sperm aneuploidy can also affect ICSI outcomes, and increased aneuploidy rates often occurs in acrocentric and sex chromosome in men with globosospermic rather than fertile men. So we can improve outcomes after ICSI with oocyte activation using calcium ionophore to stimulate those waves that are missing due to the absence of the acrosome vesicle. Thank you very much for your time. Thank you, Dr. Sandro. It was a pleasure to present this case.
Thank you very much, Marina. This is a very interesting case, and the presentation also, you summarized it well. So the case is open for you to post questions on a globosospermic patient. I would like to hear from Professor Halak, his thoughts in this case. I mean, during the pooling part, George, you need to unmute yourself. I think you are muted. Okay. The point is that the patient had recurrent varicocele, and we decided not to go for the repair because, I mean, we don't have any evidence that a patient with globosospermia could actually benefit from improving the shape of sperm. I mean, they are all globosospermic regardless of the treatment. I mean, this is more severe condition. Would you consider in a case like that? I mean, globosospermic patients, have you had cases similar that you treated, and what was your insights on these severe defects that we see, I mean, not frequently, but comes in the urological office for evaluation?
Well, thank you for the opportunity to share some of our thoughts. First of all, when the andrologists or urologists see a varicocele, the tendency is, oh, I have a varicocele, so let's do the surgery. I believe that the modern andrology scenario does not accept that fact anymore. He can have a varicocele and use cocaine. He can have a varicocele and smoke marijuana. He can have a varicocele and be obese, sedentary, use antidepressants and medications, and drink a lot of alcohol. So you must understand the varicocele in the context of the man's health. Sometimes it's a small varicocele with a huge amount of marijuana inhaled every week for decades. In this particular case, that stresses the needs for a very good andrology setup, andrology laboratory setup. In this case, I would not operate the varicocele like you did, because it would be useless, the surgery that does not change genetically the globosospermia. And I believe that what you have done by also trying to classify the spermatozoa between type 1 and type 2 globosospermia, which is not easy, as that should be addressed by many times by electron microscopy only. What I could have done besides you was to try to see by electron microscopy what are other defects between these spermatozoa. Sometimes you have also tail defects attached to the syndrome. You may have some alterations in the centrioles, in the 9 axonemes that borders the spermatozoa, and that if you find some tail defects as well as globosospermia, maybe the ICSI would be a result in no fertilization and no pregnancy. But that's something that we should study more and guess only. The conduct was very nicely done by Andrew Fert and your team, also by the oocyte side, which is activation of the oocyte was, I believe, it was very important for the success in this case. And I believe that we must, the lessons learned from this case, that we need more andrology and not less andrology. So if you find somebody that just look at the varicoceles and rushes into the surgery, which happens very often, does not trying to look at the entire men's health issue scenario, you may incur in varicoceles that does not result in successful improvement of sperm quality.
Thank you very much, George. The other point that I would like to emphasize in this case is that, I mean, you have a very severe male factor infertility, and then we need, and then the couple needs ICSI. And then we need to overstimulate the female partner. In this case, we did like that. We wanted to have more oocytes. In the first cycle done outside, she got only 8 eggs. It was good ovarian reserve. That was not, in our opinion, explored properly, because one way to overcome severe male factor infertility is by having good number of eggs. And in that case, we kind of stimulated well this patient, because we understood that we could have low fertilization rate. Fortunately, it was not the result. We were very surprised to have almost 100% fertilization rate in this case, but I mean, we were very much concerned in the beginning, actually not having that considering the previous history. So we overstimulated properly. And the other thing we did, we tried to keep it simple. Although the patient had, the female partner had 37 years old, we decided not to go for PGTA in this case. We decided, we got nice blastocysts, and discussing with the patient, obviously, everything we do here is like on a clinician-patient shared decision basis. We proposed that, okay, let's go ahead with one blastocyst back to the uterus fresh, and let's see what happens, because we have others embryos cryopreserved. So this is also something. So the coordination between, I mean, the andrological part and the reproductive endocrinologist, the IVF specialist is crucial, that we are on the same page. We understand the complexity of the cases, and we work together to ultimately benefiting, I mean, the patient. So with that, I will move to.
Can I just make a comment, Sandro?
Of course.
Just 10 seconds. I'd like to share with the audience what Dr. Sandro Esteves just said. I would stress to everybody the importance for IVF clinics to have a full andrology lab as a partner. You know, people usually have the IVF setting marvelous, and very few andrology. That's a big mistake, because andrology only helps the IVF settings. Thank you very much.
Thank you, George. Now it's my pleasure to invite Dr. Arnold Ackerman. Arnold is reproductive urologist. He was also trained with me. He did a fellowship with me. He was graduated from the University of Campinas, the urology residency program, has been staff of AndroFert since 2020. I welcome Arnold to the second virtual preceptorship in male infertility, and invite him to present a clinical case for us to discuss.
Thank you so much. Just I don't know if it's working. Okay, so hello everybody. No, it's everybody is going to be tired. It's the end of our course here, and so my name is Arnold Ackerman. It's my pleasure to be here today, and thankful to the organizer for the opportunity to present this case study. So let's go to our last case. The case refers to a 38-year-old man presenting no obstructive sperm due to Y chromosome microdeletion at subregion AZFC, and underwent a bilateral failed microtesis at another clinic. And at the surgery, the histopathology showed maturation rest at the spermatocyte stage. His wife is 42-year-old with unremarkable clinical findings, according to an evaluation done by a gynecologist with infertility expertise. She underwent an ovarian stimulation cycle at the same time as the microtesis, and 12 M2 oocytes were retrieved and vitrified. So, yeah. So we start with the medical history, and all his medical history in infertility is unremarkable. nothing to highlight with his infertility history, sexual history, or during his childhood and development. No comorbidities, no medication in use, no previous surgery or exposure to gonodotoxins, and nothing about the family history in infertility. On his physical examination, he is overweight, has normal hair distribution and no gynecomastia. His right testicle is hypotrophic, only 10 cc's in volume, while his left testicle is atrophic, only 5 cc's with normal consistency. Both vas deferens were palpable, and no varicocele was detected on this examination. Following to his blood tests, his hormone profile showed a total testosterone level on the lower limits associated with high levels of FSH and LH. Going to a genetic study, genetics reported a normal karyotype, but with a complete Y chromosome microdeletion at subregion AZFC. Okay, at this point, we have a patient presenting a non-obstructive azoospermia secondary to AZFC Y chromosome microdeletion who failed microTZ in a previous attempt outside of our clinic. And I would like to discuss the next step for this couple. Would you prefer a donor sperm, B, adoption, C, to repeat sperm retrieval without hormone stimulation previously, or D, repeat sperm retrieval after a hormone stimulation, or E, I don't know? Please vote. Let's see what you prefer. Okay. You must know that there's no correct answer here. We just want to know what's your preference. Let's check. So interesting here, talking about in this today, we're talking so much about andrology, and letter D wins. So repeat sperm retrieval after a hormone stimulation. Okay, let's check. So as many opted to do a previous hormone treatment before another sperm retrieval. If you answer that you prefer hormone treatment before a second sperm retrieval, what would you prefer as your first line treatment? Use letter A, selective estrogen receptor modulator, B, a gonadotropin, for example, HCG or FSH, or C, aromatase inhibitor. Just let us know what your preference. Again, it's off-label treatments, and there's no correct answer. Nice. We even talk so much about the gonadotropins here, but yeah, we usually use gonadotropins. So let's continue our case here. Curiously, in our hormone stimulation protocol, we relies on gonadotropin therapy, and as you can see in this algorithm, we routinely offer a hormone therapy to hypogonadal males with total testosterone lower than 350 nanograms deciliter. We use this threshold of 350 nanograms deciliter, which is equivalent to 12 nanomole per liter, to diagnose biochemical hypogonadism. So we look for biochemical, not just for the symptoms. And before starting hormone stimulation therapy, all patients sign an informed consent stating that using exogenous gonadotropins for their condition is considered off-label. There is limited evidence supporting a beneficial effect for spermatogenesis stimulation and sperm retrieval success, as we know. They are briefed about the minimal drug safety information concerning gonadotropin use in their condition, and the potential side effects disclosed in drugs lifted for patients. Also, we inform the patients that the route of the drug administration is subcutaneous using self-injection, and the treatment duration takes at least 3 months, but could be longer, depending on individual characteristics and response. So the patient must know the necessity of monthly hormone profile measurements to adjust the drug regimen and maintain the total testosterone level between 500 to 900 nanograms deciliter, which is our goal. In the e-learning platform, which Dr. Sandra already talked about, mentioned, there is one lecture dedicated to clinical management to treatment non-obstructive azoospermia, and that you can see there. So I have the follow-up about this case to share with you. Before the operation, we use an off-label hormone modulation to boost testosterone levels. We started with HCG, about 2,080 international units twice a week, which means 80 milligrams of HCG. And 3 months later, his total testosterone levels improved and his LH and FSH dropped as expected when given as HCG. And after 6 months, total testosterone levels increased and the estradiol levels increased slightly, which also is expected. We see it often after HCG therapy. It happens when testosterone levels increase because part of testosterone is converted to estradiol by the aromatase enzyme. And if we divide the testosterone levels here, 455 by the estradiol levels 49, the ratio will be 9.3. So levels below 10 are considered abnormal, indicating aromatase hyperactivity. For this reason, we introduced anastrozole, an aromatase inhibitor, 1 milligram twice a week. And we did not introduce recombinant FSH once the FSH level was above 1.5 international units per liter. At the time of microtesia, after 9 months with hormone stimulation, the hormone profile was adequate with a total testosterone level above 500, our goal that I said. And the total testosterone to estradiol ratio was above 10. However, all semen analyses reported azoospermia for each follow-up. So during the microtesia performed bilaterally, so it was a defined surgery for this patient, only on the right testicle we were able to retrieve viable sperm. As you can see in the top of the right screen here, we can see the diameter of the seminal tubulus. The largest seminiferous tubulus diameter showed 280 micrometers, and the retrieved sperm were cryopreserved with a cell sleeper method. And we took a specimen for histopathology analysis too. So we devitrified all sites that was transferred for another clinic, and we did the ICSI procedure too. Well, so everyone can access the e-learning platform of this course, as Dr. Sandra has already mentioned, and read the visual map about how we perform the microtesia at Androfert. It's just a small picture here in your right. So, and moreover, the video lecture, it describes this procedure step by step, including the role in the vitro fertilization laboratory and the sperm retrification technique using the cell sleeper I mentioned before, and in this case. Interesting and important to highlight the histopathology improvement after gonadotropin therapy. On your left, we can see maturation arrest histopathology, in which this patient underwent a negative microtesia first. And after hormone treatment, There is still focus of maturation arrest, but also areas in the red arrow that you can see here with hyperspermatogenesis, allowing a positive second microtesis. With more detail here, we can see spermatides in the green arrow, signs of sperm production compatible with hyperspermatogenesis. It confirms the improvement with hormone treatment in which cells that were arrested could continue differentiation until sperms. And finally, in this case, it resulted the IVF cycle done subsequently. 12 oocytes were transferred from another clinic. 10 were in M2. 8 of them were fertilized, and 3 embryos developed and were petrified. Unfortunately, we don't have the outcomes of this case, but we are planning to do the embryos soon. So thank you for the opportunity again. Thank you for your time. And I'll go ahead again to Dr. Sandro.
Thank you very much, Arnold, for presenting the case and also highlighting some of the important aspects in this patient as well. I mean, one issue is that when we have a case in which failed ICSI, failed microtesis bilaterally in another clinic, it's very hard to accept the case, because if we propose, I mean, any treatment, we run the risk of fail again. So we need to have very big discussion, causal discussion with the patient and the couple, looking into several aspects. And even if we consider hormonal stimulation like we did in this case, it's important to discuss that the evidence is quite limited. We have just recently in Human Reproduction Update paper summarizing the evidence related to hormonal therapy in men with non-obstructive azoospermia, in which shows a significantly higher sperm retrieval rate for the treated group, but still most data comes from small case series, observational trials. We don't have randomized control trials, so this is using gonadotropin therapy. Specifically, in this case, we used recombinant HCG. It's off-label therapy that we need to discuss with the patient. So this needs to be emphasized. And also the European Association of Urology, in the guidelines that they published last version, say that hormonal therapy should be done inside clinical trials. On the other hand, the ASRM AUA guidelines in male infertility, they emphasize that the treatment could be discussed with the patient. I mean, this is also, you see variation in the preferences, but we see in the polling question that 70+% of the participants actually consider hormonal stimulation. And the interesting point in this case is that we did it not combined with the thawing of if this patient actually, because the oocytes came from another clinic, they were cryopreserved with us. And then when we got sperm, actually, we devitrified the oocytes and made the embryos, but the patient was not prepared, obviously, for getting the embryo transfer because we are completely unsure of the outcome. Despite the increase in the hormonal levels, the nice levels that you saw at the end of the case, we cannot guarantee that the increase in testosterone levels translates into a positive sperm retrieval. So I thank you for that, for listening, and I would like to listen to Professor Halak, his opinion about case like that. He's very experienced in non-obstructive azoospermia, has seen many patients, and also I welcome George for his input in the case that Arnold presented. Please, George.
Well, again, congratulations on the conduction of this case, on how you conduct the whole case, not just on the male side, also on the IVF lab and etc. Well, I'm a big fan of gonadotropins. I've been using gonadotropins since, let's say, 19 to, let's say, 20 years now. And I believe that gonadotropins present, regardless being off-label use, together with the proper antioxidants according to the level of oxidative stress and etc., like I said before, is a huge increment in the andrology armamentarium. So I believe that the proper use of gonadotropins and other medical treatments can really improve, but only if you have an andrology lab that you can see small differences in sperm quality. If you don't have the andrology level expertise to really enjoy, to really see what's going inside the sperm cell, if you only have basic semen parameters, maybe you just don't see all the benefits that can be there. And I believe that the monocytic azoospermia and microtazy, I never do microtazy immediately when the patients come to the clinic. I do believe that you must give a shot of HCG before going for microtazy, because a failed microtazy is a burden to the patient, not just economical burden, also psychological burden, social burden for the wife, because I believe that is nobody does microtazy and cryopreserved testicular parenchyma without the ovarian stimulation at the same time, except for some groups in the world, because testicular cryopreservation for obstructive azoospermia is something. Testicular parenchyma cryopreservation for non-obstructive azoospermia, the results are suboptimal. And so I believe that, like Sandro said, 6 months delay for starting ovulation, induction, and IVF cycles is not a killing time. So treating IVF and infertility as appendicitis or acute cardiac arrest is not the way to go in IVF anymore. I believe that we should treat the male accordingly and give a chance for improvement. Not to mention those patients that were previously cryptozoospermic, with only some spermatozoa seen in the semen analysis or after microcentrifugation, that he can ejaculate viable sperm for ICSI and not in need anymore for microdissection. We have sperm cryopreservation techniques, like he said, the Serge Slipper and others, that you can use. So a percentage of these men will avoid microdissection and not even go for these stressful techniques. Thank you.
Thank you very much, George, for the inputs. I think we are now coming to the end. I think we have now closing slides. I would like to thank all of you who participated today, all the AndroFert staff for participating and help us to conduct this preceptorship. Also, Professor Halak, you made our preceptorship today very live. George, thank you very much for the fantastic work that you have been doing academically, clinically. Thanks a lot for participating. So now I want to share some final thoughts with you. So again, thanking the societies that partnered with us for this preceptorship, all the societies that I mentioned before. Without your support, the success of this program would never be the same. Please complete the post-webinar survey that you received by email in order to get your CME certificate of attendance, and also the diploma that we'll sign for you. And don't forget to join us next Friday on December the 2nd, directly from the United States, in North Carolina, the Atlantic Reproductive Medicine Specialists, live session hosted by Dr. Matt Coward and his group. Let's discuss with them how they approach the male infertility. It's gonna be very interesting. Matt Coward participated last year, also with a live session, and it was very, very well received. So I invite you to attend this session as well. And then on December the 10th, join us in Denmark directly from Skive Fertility Center in Skive Regional Hospital, which is affiliated with University of Aarhus, with Professor Peter Humayden and his group. He's gonna also share his approach to male infertility. I was just with Professor Humayden visiting his clinic a few days ago, and he's very excited about the upcoming live session in his clinic, preparing very interesting things for all of you. So thanks a lot for joining us today. Also to Medical Education Academy, all the group that supported us, Chloe, Andrea, who are in the backstage, making sure that everything goes smooth. Have a nice weekend, everyone, and goodbye.
Thank you. Bye-bye.